Good afternoon, folks. I'm going to go ahead and get the meeting started for today. My name is Mitch Rodriguez. I'm sitting in for Dr. Curran. Dr. Curran was not able to be with us today, so he asked me to sit in for him. Hopefully, I'll do him justice in that respect. I'd like to start the meeting by calling it into order and then going on and start the roll call. We'll start off with the roll call. Dr. Curran, absent. Mr. Harper, absent. Myself, Dr. Rodriguez, present. Major General Thomas Carden.
Present. Over.
Dr. Cheek.
Present.
Great. Dr. Cowles.
It's Coles. Present.
Great, thank you. Dr. Mercer. Dr. Mercer, you may be, I see your mic, you're here present, your mic is on mute. Dr. Shin. And Dr. White.
Present.
Thank you. We'll go on into old business. Everyone had an opportunity to receive the minutes that were sent by Ms. Fanny Vasquez, and you've had an opportunity to review those, see if there's any questions or if there's any motions or any changes that need to be made. If not, I'd like to ask for a motion for approval in second.
This is Major General Carden. I move to approve. Over.
Thank you, sir. Can I have a second?
This is Dr. Cheek. I second.
Thank you. Any opposed? So being, the minutes stand approved. We'll move on to new business. I'd like to turn the microphone over to the Commissioner, Dr. Toomey.
Much, and thank you for being here today. We wanted to give you an update on our response to the pandemic, which is continuing, as you know. But also the other thing that has happened since we last met is the legislative session has begun. That always presents challenges and opportunities for us in public health as well as in other areas. And I thought it was important for us to reintroduce Megan Andrews, who you may remember from before, who recently returned after a wonderful time off. Am I allowed to say? Yeah. It's not a HIPAA violation. She has a beautiful baby boy, and I'm her pretend godmother. But we are just grateful for her assistance during this session. And I thought it was important for her to outline some of the more challenging and also engaging issues going on at the Capitol right now, because we will need your help and some ideas about how we can approach some of this legislation. So thank you, and I'll turn it over to Megan.
Thanks, Dr. Smith. Hi, everyone. Good afternoon. It's great to be back. We are already deep into session. For those of you that are familiar, there's 40 session days of each legislative session. Today is another session day. We're on day 13. Crossover day, which is the 28th day of session, is scheduled for March 15th this year. And what that day is any piece of legislation that does not cross over from one chamber to the other is then dead for the rest of the year. So that's an important day and usually a very busy and late day for us, tracking everything that's going on and crossing over from the House to the Senate or vice versa. And then the last day of session, which is called Sine Die, is scheduled for April 4th this year. So after Sine Die, we usually put together a report for the various department heads here at DTH and the commissioner on everything that happened that session, our marching orders for any sort of legislation that we need to implement or change operations. So we can expect that probably towards the end of April after session is over. Next slide. So it seems to be a crazier year. I've done this for a couple years now. I'm sure you all that have been on the board for a while remember the past But this session seemed uniquely busy. We are so far tracking 162 active bills that touch on public health in some way, shape, or form. Now we're only on day 13, so day 28 is crossover day. People are still introducing bills, so there's still a long way to go for the rest of the session and more bills to come. We are seeing a significant number of bills that do have a direct impact on DPH. What that means is that they will either require us to change our operations in some way, or require us to start up a new program, things of that nature. So 56 of those bills do have a direct DPH impact. And I put some data from session 2 years ago, just so you guys have a little bit of a comparison of how many of these bills that we're tracking actually do impact our operations. And we are seeing more direct impact bills this year as opposed to previous years. Next slide. We did get approval from the governor's team to pursue 4 agency bills for this year. So I'll talk about them briefly, and I'm sure some of you may have questions or want to chat about them, and I'm happy to do that as well. The first one is our childhood lead poisoning legislation. There was a study committee that met this summer and fall talking about childhood lead poisoning and how Georgia's laws are out of compliance with CDC recommended best practices. So we are pursuing agency legislation that will bring Georgia law into line with CDC best practice standards as far as what blood lead level would warrant public health intervention. And interestingly enough, during the study committee process, CDC actually changed their recommendations again, further lowering the blood lead level to 3.5. Before that, it was 10. And Georgia 5, and Georgia law was at a level 10. So we were a little behind the 8 ball on being in line with best practices. So this bill will help bring that up to speed. We had a couple changes to the bill draft. So that bill I expect to be dropping in the next few days or so on the House side. The next bill is a EMS Scrap Bag Bill, is what it's called. That's Senate Bill 404. It passed out of Senate committee last week, and it's awaiting a floor vote on the Senate. And what this bill does is it allows our EMS program to retain, well, not the EMS program, but GBI to retain the fingerprints for EMS licensees, and then notify the agency if there's a criminal violation or something that would pop up on a background check after the initial licensure period. So a lot of other state agencies have this ability already. Think of really any sort of state agency that assists individuals that are kind of in high risk settings. So like long-term care facilities, they allow this wrap back provision for employees of those facilities, DFACS workers, things like that. So this is just also allowing our EMS program to have that same capability. The third one is the Smoke-Free Air Act and vaping. This was actually brought to our attention by one of our health districts and a restaurant inspector that came back with questions after inspecting at a restaurant. So the Smoke-Free Air Act prohibits smoking in certain locations, in restaurants, for example, schools, things like that. That law was drafted many years ago, before vaping was even created or invented. So this proposal will add vaping to the Smoke-Free Air Act. So anywhere where you can't smoke a cigarette, you also can't vape. So we are in the bill drafting process for that legislation as well, and expect that to drop in the near future. The last one that we are pursuing as an agency bill is the filming of patients in healthcare facilities. So this actually was brought to our attention by some of our health departments. We're having an issue with members of the public coming in and recording patients in some of our waiting rooms. And surprisingly enough, it wasn't a criminal violation to report patients in like the waiting areas of certain facilities. And this is particularly concerning because a lot of our health departments have things like Brian White clinics that serve the HIV population. And we certainly want the individuals that come utilize public health services to feel comfortable and confident in the confidentiality of receiving those services. So it's really important that any sort of filming or recording that takes place is done 100% with that patient's consent. So we are proposing legislation and hope to have that dropped in the next couple days or so about prohibiting the filming of patients in healthcare facilities without their consent. So we have a very busy year. There is a lot of narrative going on at the Capitol with regard to COVID and vaccines and all things public health. So we are certainly keeping abreast of all of that and making sure our legislators are well informed and educated on all things public health before making their decisions through the legislative process. But it has been a crazy year, and I'm sure it'll just keep getting crazier as we go through session, but I appreciate your time and I'm available for any questions.
Thank you, Megan. Are there any questions for Megan from the board that would like some clarification? Okay. Megan, let us know of anything that we could do to help you, assist you in this process. Thank you very much for the report. I'm sure that you're going to have a busy month ahead of you in that respect, with a lot more information for our next meeting. Thank you. So a quick update to the roll call for today. I see that Dr. Schindler has been able to join the call. If you could just make sure that we mark him as present as we move forward. On the next item for the agenda today, it will be Dr. Dresnick, who will be providing us with a update on COVID in that respect. Dr. Dresnick.
Hi, everyone. Thank you so much. It's a pleasure to be with you again this afternoon. So what I would like to do is actually just give you a brief update about the landscape of the COVID pandemic here in Georgia, similar to the format that we used last month. And I think I have some better news today, but let's take a look in a little more detail. So just initially, just kind of a snapshot overall. So far in the pandemic, we've had more than 2.4 million cases of COVID, more than 104,000 hospitalizations, and more than 33,000 deaths. So what's been going on over the last 2 months? Essentially, we have experienced and are continuing to experience the Omicron variant wave or surge. It began here in Georgia in the very beginning of December, and we saw our daily case counts skyrocket from essentially like 1,500 a day all the way up to 25,000 cases a day, and even higher than that at the peak, and essentially staying nearly that high throughout January. However, over the last week or so, we are now starting to see consistent, sharp declines in our case numbers. Over the last 7 days, our case numbers have declined by 51%, and we're down to about 4,000, 4,500 cases daily over the last several days. The other surveillance indicator that we look at when we're looking at transmission and transmission settings here in Georgia are our outbreaks. So our outbreak numbers are actually also decreasing. We had 116 COVID outbreaks reported this past week, down from 156. What we're seeing in regards to the most frequent settings for outbreaks are that about half of them occurred in K through 12 schools and about a quarter in daycare facilities. And we also are seeing 10% or so in jails. But one of the kind of very vulnerable congregate settings such as long-term care facilities, we were seeing most of our outbreaks there, during the beginning of the Omicron surge. And now that one has actually declined quite a bit. And, we're seeing more and more outbreaks, primarily now in school and child care settings. That varies a little bit, but it also just indicates to us that these are areas where transmission is still occurring, and that are areas for us to look at in regards to mitigating transmission. Next slide, please. As we saw these huge case numbers, skyrocket, we also saw hospitalization numbers increase greatly during the Omicron surge. However, they were not really anywhere near the case levels. And we refer to that as they were decoupled from cases. So they're quite a bit lower, but still at very high levels that could strain hospital capacities. Also, over the last week or so, we are now finally beginning to see declines in our hospitalization numbers. About 50% or so decline we saw in the last 7 days in hospitalization numbers, which is also good. But again, as I mentioned before, even though they're declining, they're still at relatively high levels, which can, again, certainly strain our hospital partners. The one area of surveillance that is, again, not declining, at least not yet, are deaths, COVID-related deaths. These numbers are still increasing here in Georgia. As a matter of fact, our death numbers increased by about 86% over the last 2 weeks. And again, the death numbers are often what we call lagging indicators. They lag behind case numbers by at least a few weeks. But again, tragically, we're still seeing increasing numbers of deaths, and this looks like this has not peaked yet. About 55% now of our Georgia population is fully vaccinated, and 21% of our total population is now boosted. And so the reason I bring that up is that, again, even though during the Omicron surge, we saw breakthrough cases with those huge case numbers, certainly we did see infections with Omicron variant, but the hospitalization and death numbers, again, remarkably, are still among the unvaccinated. So the vaccines, particularly full up-to-date vaccination with a booster, held very well against severe outcomes. And so we still, have that available to us to continue to prevent hospitalizations and deaths. Nationally, the picture looks the same. Again, plummeting cases, declining hospitalizations, and increasing deaths still. Okay, next slide. So now what I'd like to do, just in pictures like we did last month, is just very briefly kind of take a tour visually through those main surveillance indicators: cases, hospitalizations, and deaths. So first of all, let's look at our case numbers and look at the epidemic curve. Cases are on the left, and I also have PCR positivity rates on the right-hand side there, so you can see. Look at this plummeting, sort of number of cases. Here we were on the far right of the graph, huge case numbers, and now over the last week or so, we are finally down, again, like I said, more than 50% to about, 5,000 cases, 4,000 cases. The yellow line is a 7-day average. So even if you look at that, if you look one peak over at the Delta wave, we're very grateful and very glad that these numbers are declining. But if you see where they are right now, we're still, not too far off where we were in the Delta peak. So albeit we love the declines, but we still have a high risk of transmission. These are still quite high levels. Our PCR positivity rate also went from a stunning, at the peak of Omicron, mid 30% down to now we're, over the last few days, we've been like 17%, 15% or so today, which is, again, still quite high. And if you look at the right-hand side graph, if you look at the Delta wave before it, we're still kind of way above there too. So again, we still have plenty of opportunity for Omicron transmission. Next slide, please. As has been true throughout the pandemic, just very briefly, the individuals that are being infected are by far and have been throughout every single wave, the young to middle-aged adults, 35 to 54. This is not any different in Omicron and continues to be the same. But again, just look at the sort of scale and magnitude versus the other waves. Next slide, please. So here's our next surveillance indicator, and these are the deaths. I wanted to kind of give you a feel for where our death numbers are going. So the case numbers peaked here, sort of mid to late January, and that's when we just started to see these death numbers starting to continue to go up on the far right-hand side. So our death numbers now, again, if we're looking at the 7-day average in the yellow line, as we're increasing still, we're still going up. As we look at this Omicron wave on the far right, this is a little different than the, sort of case and PCR positivity rates in the sense that this one is not as high as we saw during Delta. So this is indeed, although these are all, again, tragically preventable, because of vaccination, again, we are still seeing less severity because of vaccination and because of Omicron. So we're not quite as high as we were death-wise during the more severe Delta wave as well. So next slide, please. And again, when we look at the trends by age group, has been true throughout the entire pandemic, no matter the wave. Individuals over the age of 65 are the most frequent, it's the most frequent age group in which fatal infections occur. And again, if you just sort of look at the magnitude of these waves here, look at our Omicron death wave now. Again, really less than half of what we saw during Delta. And again, if you go all the way back to last January, that's a testament right there of what vaccination can do. Vaccination became available January 2021, and so these death numbers have gone down ever since. Although, again, I just want to reiterate, absolutely preventable in many, many, many cases. Next slide, please. So here's our hospitalizations over time. And again, we're starting to see very consistent, sharp declines in hospitalizations as well. This graph shows you really the daily census of COVID patients in hospitals. And as you can see, we're starting to come down about, again, close to 50% or so from a few weeks ago. But again, our hospitalization numbers here are during the Omicron wave are not as high as case numbers by any means. But really, if you compare them to the Delta wave, they're not all that far off. And this is why we saw so many of our hospital partners and hospitals having strange capacities. One thing that is different, even though we've had a lot of hospitalizations, our ICU bed usage and our ventilator usage during Omicron has definitely been less than during Delta. As a matter of fact, the ventilator usage has been almost half what it was during Delta. Next slide, please. And again, as has been fairly consistent with deaths, the severe outcomes and hospitalization trends by age group also primarily we are seeing throughout the pandemic, the most frequently hospitalized age group is those over 65. And second place is really the younger adults, younger to middle-aged adults, 35 to 54. And that's very reflective in some ways of them being the most frequently infected, for one. But look at the Delta wave, one to your left, and that is we had many more younger people hospitalized during Delta. Okay, next slide, please. So let's put all three of those surveillance indicators together. And again, this just begins from the beginning of January last year, just to really so you can see it a little clearer. So here is essentially last January's wave, the Delta wave, the Omicron wave. you put the three on top of each other. Red is cases, blue is hospitalizations, green is deaths. Look at here's where this decoupling, meaning we have had, greatly increasing hospitalization numbers over the during the Omicron wave, but nowhere near, where we are with case numbers. If you go back into the blue line for Delta, again, the proportion of hospitalizations versus cases, is much greater. But look at this death numbers. Again, these deaths are so low in Omicron, especially relative to hospitalizations and deaths. Again, a testament to two things: vaccination and boostering, and also the less severity of Omicron as well. Again, I have to say it one more time: preventable. These are unvaccinated people. Next slide. All right, let's show this in a little different way. I haven't shown you something like this before. Basically, what I want to do is, as we're talking about testament to vaccine status, meaning individuals that are either fully vaccinated or fully vaccinated and boosted, this slide just breaks it down in three ways. We're going to look at cases, hospitalizations, and deaths. The black line in these graphs represent individuals that are not vaccinated. The red are fully vaccinated, and the gray are boosted. So take a look at, again, upper right, see clearly case numbers by far occurring in the unvaccinated. But let's look at those severe outcomes. This is where we see this tremendous impact of our vaccination and boosting status too. Look at how far down, having a booster dose brings you in regards to hospitalization. This gray line way at the bottom versus those that are unvaccinated in black, and those even that have 2 doses in red. So there's your hospitalizations on the left, deaths on the lower right, and clearly even just that magnitude of deaths during Omicron, looks much, much different than it did in Delta. And that is, again, related to inherently the lower severity in Omicron, but also look at what the booster can still do for us. And that's a really, really important message. Next slide, which is my last one, just to summarize all of this together. Clearly, we've all experienced this Omicron wave that had arrived in early December and peaked in late January. Case counts are plummeting by at least half nationally and here in Georgia, albeit we're still at high levels representing risk of transmission. Hospitalizations are declining, but also constrain hospital capacities. And our ICU and ventilator use is lower than it was during Delta. Deaths, unfortunately, are still on the rise. And as I had shown even by that previous slide, up-to-date vaccination, which means including the booster dose, is strongly protective against these severe outcomes. And the data are bearing out more and more. I think the most important message that I would like to say is this one sentence. Unfortunately, the pandemic is not over. By far, we still need to, again, promote vaccination and boosters as we can, other mitigation strategies as appropriate. That's critical if we're going to continue these declines, and if we face other variants or changes in variants. Again, all of these tools in our arsenal have not changed from day one. And I thank you so much for your kind attention.
Thank you once again, Dr. Drenzik. And any questions from the board for Dr. Drenzik?
Yes, it's Dr. Coles.
Yes, sir.
Would you mind defining up-to-date vaccination?
Yes, that term essentially CDC uses to refer to individuals that have had a primary 2-dose series plus a booster. And the up-to-date vaccination, actually, you become up-to-date as soon as you get your booster immediately. So those with a booster.
Well, thank you. I was actually implying that definition may change as we define antibodies and actually resistance to disease. Do you agree?
Sure. yes, and again, we use that terminology as CDC does, but certainly that we imply that there are, there are many other layers of host factors and immune factors that actually contribute to immunity to this disease, both on the virus side and on the host side as well. So.
I just have many patients that are beginning to ask me, they say, well, I'm fully vaccinated, but what do I need to do in the future?
Sure. So again, I think that it's very, very important that if they are fully vaccinated and they have had a booster dose, then the other usual mitigation strategies apply. As we're starting to see these transmission levels decline, the risk goes down as far as exposure goes as well. But certainly, kind of from my perspective, having a primary series plus a booster, according to recommendations, is the absolute way to go, particularly for severe outcomes. And we are still going to see some infections. Certainly not any vaccine is 100%. So yeah, thanks so much. I appreciate that.
Thank you. Thank you for that summary. I really like that graph on death by vaccination status, and that's really important to see in that respect. It kind of highlights what you've been speaking of over the time. Anything in the near future that we need to be prepared for as we move forward, or is anything out there that's coming our way that we are aware of?
I wish I knew entirely, but I know that there are some countries that have experienced, after their Omicron surge started to decline, they experienced some increases related to a sister sublineage of Omicron called BA.2 instead of BA.1. We've seen very little of it here in Georgia and in the United States as a whole, although we certainly, like, for example, in Denmark, this sister sublineage is driving another surge there. So whether that occurs somewhere here in the U.S. Remains to be seen, but it looks like it behaves very similarly, meaning that it spreads really rapidly, but also is very, it again does not evade, sort of immunity differently than Omicron 1. So more to come.
Thank you. Dr. Cheek, did you have a question? I saw your hand up. Okay, thank you. Well, thank you, Dr. Drenzik, for that information. Appreciate your time in that respect.
Thank you all. Thanks.
We'll move up with therapeutic updates. Dr. Millen.
All right, good afternoon, everybody. I'm going to provide an update on COVID-19 therapeutics. Next slide, please. So the outpatient therapeutics that I'm going to be talking about, they're similar to what I had talked about during the last therapeutics update. However, there have been some changes with FDA in terms of the monoclonal antibody treatment. So what you'll see is that what we have available right now for treatment of COVID-19 in an outpatient setting for mild to moderate disease for patients who are at high risk for severe outcomes there's one monoclonal antibody, Sotrovimab. Remdesivir is the intravenous antiviral that's available for outpatient treatment, as well as 2 oral antivirals, Molnupiravir and Paxlovid. I didn't include on here Evusheld, which I had talked about during my last update, because that is used for pre-exposure prophylaxis. And I'm focusing today on just what's happening in the treatment space. Next slide, please. So for monoclonal antibodies for treatment, on the 24th of January, that should be 2022, the US FDA announced that 2 monoclonal antibody treatments for COVID-19, BAM-EDI and REGEN-COV, are currently not authorized for use in the United States due to their limited effectiveness against the Omicron variant. Sotrovimab, fortunately, has maintained activity against Omicron and is still available for use for treatment of non-hospitalized individuals with mild to moderate COVID-19 at high risk for severe outcomes if administered within 10 days of symptom onset. Next slide, please. For the intravenous antiviral, so Remdesivir, which has previously been used throughout the pandemic for hospitalized patients, can also be administered to non-hospitalized patients with mild to moderate COVID-19, and it should be initiated within 7 days of symptom onset. This one update that has occurred since the last presentation is that CMS has now created a J code for remdesivir when administered in an outpatient setting. So this code is effective for dates of service on or after the 23rd of December, 2021. And I wanted to just provide that information, as this should also help practices that potentially may be interested in using this so that it can be used for billing purposes for administering this treatment for those patients who qualify. Next slide, please. And then finally, for the oral antivirals, there's not really major updates on this. Treatment with Paxlovid or molnupiravir is for non-hospitalized patients with mild to moderate COVID-19 who are at high risk of disease progression within 5 days of symptom onset. Next slide, please. So we continue, as was the case with the last presentation I had, we continue to have extremely limited availability of monoclonal antibodies and oral antivirals nationally. So sotrovimab is on a weekly allocation cycle, and the oral antivirals are on a 2-week allocation cycle. We just got updated allocations yesterday. So for molnupiravir, we received slightly fewer than 10,000 treatment courses for the 2-week time period. For Paxlovid, it was a little less than 2,500 treatment courses for 2 weeks. And for sotrovimab, Georgia received about 1,600 treatment courses for the week. So again, even though the case numbers have been declining, which is good to know, and it's very reassuring, the number of available treatments that we have are still extremely limited in Georgia. Therefore, when we do our allocations, due to the limited supply of sotrovimab, we are currently prioritizing hospitals and long-term care facilities for those allocations, given the high-risk patient population that potentially are going to be using or in those settings. Remdesivir is not on federal allocation and is available for direct purchase from the manufacturer. So the federal government and the state do not have a role in remdesivir for facilities. Next slide, please. For the oral antivirals, just to review, DPH has partnered with Walmart, Walgreens, and Good Neighbor Pharmacy Group, which is a group of small independent pharmacies, to try to ensure statewide coverage. Since the initial rollout, we have increased the number of pharmacy locations in urban and rural areas throughout the state. In an effort to also increase access to certain areas that have populations that may have been harder to reach through these pharmacy partners, we are also working with the Department of Corrections as well as long-term care facility pharmacies to try to improve access for the high-risk populations that are in those settings. And then as we have been saying, as our allocations increase, unfortunately, they hadn't increased this month for us to be able to do so. But as they increase in the future, an ordering process will be made available to other therapeutics partners that are interested in dispensing these products. Next slide, please. So this map is available on the DPH website, but I just wanted to show you where our oral antiviral vendors are located in the state. We have tried to get sites that are available in both urban and rural settings and try to extend, and we have onboarded additional pharmacies as time has gone on so that we have been able to try to get pharmacies in more counties. Next slide, please. So for locating treatment providers, the monoclonal antibodies are currently found on this website, on this HHS website. For Evusheld and the oral antivirals, there's another Therapeutics Locator tool that is that's available. This Therapeutics Locator tool is particularly useful as they show what the current inventories are in the pharmacy locations throughout the state. So you can actually see as a prescriber or as a patient whether or not the product is available in one of the stores that is in your area, or if you would need to think about using a different facility. We are told also by HHS that sotrovimab is going to be put into the Therapeutics Locator at the bottom of the screen in the future, as they integrate the data system for the monoclonal antibodies with the oral antiviral ordering system, so that providers and patients will also be able to see where sotrovimab is located in the state at a future date. Next slide, please. So those are really the updates that I have on what's happened. So please let me know if you have any questions about any of the content.
Thank you, sir. Appreciate it. Any questions from the board? Any clarification that's needed? Great. Thank you for your time.
Just something really quickly, Dr. Rodriguez.
Yes.
The feedback I've gotten from many people is that there isn't always the antiviral available in the pharmacy near them, and yet other pharmacies have really have a lot of this antiviral medication, and local physicians are simply not prescribing it. We sent out a letter, and I hope you all received it, you who are physicians, describing how to prescribe the antivirals to try to encourage more use of the antivirals throughout the state, particularly with the relative shortage of sotrovimab. And we're hoping we'll see this equal out. And again, as we are also getting additional doses of antivirals in the next several months. But the availability really is variable from location to location, and even in rural areas. Some are totally sold out, others have almost no utilization. So we're again trying to encourage the provider community, and that's one thing you can do to help us, to remind them about the availability of these antivirals and to use them in the same way we use Tamiflu and other antivirals. Thanks.
Thank you, Dr. Jimmy. We appreciate that. Great. So we'll move on at the agenda with Rustin on the vaccination and testing updates. Dr. Rustin?
Yes, thank you. So some of these slides are going to look similar. I've tried to update a few numbers and have some new information to share. Next slide, please. So this particular slide is a snapshot of where we are overall with vaccinations. As you can see, as of last night, Georgia's administered over 14 million vaccines. And then it's broken down of around 6.4 million first doses, 5.6 million of folks fully vaccinated, with 38% of those fully vaccinated boosted, which makes up about 20% of our overall population. Breaking that down, though, by vaccine type, you can see the pie graph on the right. Because Pfizer was the first vaccine approved, about 59% of all vaccines administered have been Pfizer. 2% of that of the vaccines are in that 5 to 11-year-old range. But out of that 2%, 19% of children in that age range have received one dose, and 14% are fully vaccinated in that 5 to 11 age range. And when you look at the 12 to 16 age range, 44% have received one dose, along with 39% are fully vaccinated. And the reason I highlight that is I'm going to give you some updates on a new vaccine that may be coming out very soon for even younger children. Next slide, please. Our total number of COVID vaccine providers is pretty stable. We have around 3,400 providers across the state providing vaccine. But we wanted to kind of break that down to see how many are active in the last quarter. And as you can see, 81% of the providers have administered at least one dose in the last quarter. And so we have quite a number of providers that are still very active in administering vaccine. And these are broken up into a variety of provider types. Obviously, private providers, which is all of the major disciplines, primary care, pediatricians, our public health clinics, which is also includes community health centers, our pharmacies, independent and chain pharmacies. And then, as you can see, it's broken down into even different types of providers, hospitals, long-term care facilities, our correction facilities, and the military. Next slide. These few vaccine updates since our last meeting, I think are pretty important. The FDA had actually reached out to Pfizer because they are sort of, I guess, leading the pack with clinical data for this 6-month to 4-year age group. They have recently submitted an EUA. They're calling it sort of a rolling submission. Their particular vaccine for this age group is a 3-dose series at 3 micrograms per dose. They have submitted data for the first 2 doses to FDA, and will submit that 3rd dose as they acquire more data through their clinical trial. FDA has scheduled a vaccine advisory committee meeting for February 15th to review that data. So, it's hard to say at this point what they're going to vote on, but I do think pretty soon in the future, we're going to see a vaccine available for the much younger children. FDA recently granted full licensure to Moderna's COVID vaccine, just like Pfizer has full licensure for their vaccine in adults. The COVID vaccine is now, for Moderna, has been approved, and the brand name is Spikevax. ACIP and CDC accepted that recommendation and endorsed that approval, and there was very minimal changes to clinical guidance for that particular vaccine. And then most recently, a new vaccine has been submitted. Novavax has submitted a request for EUA for a new protein-based COVID vaccine. This is basically a purified protein antigen that they derive from the spike protein of the virus. This vaccine is a sort of I guess, a new tool that'll be available when approved. Its technology is based off of some older technology used to make vaccines that we currently give, like shingles or hepatitis. And so those are just a few of the vaccine updates on the horizon. Next slide, please. Long-term care facility boosters. This is very important to us, for this particular population that's at risk. We've been working very closely with the Georgia Healthcare Association to assist them and provide any assistance we can provide to long-term care facilities to encourage and increase booster rates in those facilities. One thing that we've recently done is we started a campaign of reaching out to every single long-term care facility that enrolled in the federal program initially. So this program was, if you remember, in the initial vaccination phase, the federal government partnered long-term care facilities with either a CVS or a Walgreens pharmacy. And so we have that list. We've reached out to all of them, and you can see the statistics. We've made contact with 100% of all those facilities. It's over 1,000 facilities. 25 of those facilities were referred, were referred to our vendor for partnership potential. 61% have stated that they either have a partner or they have already been partnered by DPH or CDC and do not need assistance for boostering. About 18%, 19% were non-responsive, so we're still working on contacting them. Some of those facilities have closed, or we have to get updated contact information. And then we have about 18% of those facilities that we're still pending outreach. We've left messages hoping that they'll call us back. But this is just one project that we've been working on over the last few weeks to try to increase the booster rate amongst the residents. As you can see, as of February 3rd, our booster rate amongst residents in skilled nursing facilities is around 73% and about 32% amongst staff in those facilities. And so we certainly have opportunity there, especially amongst the staff. Next slide, please. For jails and correctional facilities, we continue to work with our vendor to prioritize this population. As Dr. Drenzik had mentioned earlier, the outbreaks seem to be declining in this particular population, but we do continue to work very closely with our vendor to connect them with various jails and correction facilities. So those sheriffs, those police chiefs, and in some cases, some of the federal facilities have access to vaccinations. At this time, over 40,000 vaccines have been administered in this population. And then you can see the breakdown, about 14,000 first doses, a little over 11,000 second doses, and between additional doses and boosters, approximately 15,000 doses have been administered. Next slide, please. I wanted to provide just a few statistics on our COVID call center. You know, when we look at our call center metrics, we stood this up so it really, for folks who don't have access to internet or have trouble using the internet, we wanted there to be a number that people could call to assist with questions, to assist with scheduling appointments. As we look at these metrics, you know, we try to balance the number of call agents with demand. And right now we're averaging about 97 agents per day, and our call center is open 7 days a week. When I looked at the statistics recently, over the last 5 months, we're still averaging over 8,000 calls a month. And so they are busy. Since this call center has been stood up, over 366,000 contacts have been made, and it's broken out into calls we've received or outbound outreach calls where we've contacted people that's left messages. And then we also have a chat system online that people can go to and chat with agents, and then various articles that they are directed to from that chat. And so we will continue to monitor this, and if the statistics still require it, we will keep this call center open and available to the public. Next slide, please. On the testing front, just as case numbers have declined, our testing numbers have declined, and I'll show you a slide shortly on what those numbers look like. But in the month of January, since January 1st, our health departments and our vendors that partner with us have managed over 175 of our spot sites, our testing sites. When I presented the last month to you, it was about 163 sites, and so we've increased some of our sites. Since then, we have opened 3 mega testing sites in the metro region and 18 surge sites all across the state. And we continue to offer testing, even though our numbers are declining. You know, we are having discussions that in lieu of closing sites, we would rather modify hours of operation, because it takes longer to stand a site up than it is to keep it in place, obviously. And from a staffing perspective, we want these opportunities to be available. The chart just provides a breakdown of our health department sites, which is mostly rapid testing, and then our various vendors that are assisting us through offering PCR testing. Next slide, please. This slide is just sort of one of our internal dashboards where we monitor all the testing across the state for our public health sites. The dashboard on the left gives you a snapshot from day one, literally from the very beginning of the pandemic to where we are today. And as you can see, our public health sites, every one of those dots is either a testing site or a former testing site that could be stood back up. And our goal was to saturate the entire state over a period of time, which I think we've done very well. For our public health clinics, since the beginning, over 2.6 million tests have been offered or have been collected through our public health sites, and about 36,000 of those were rapid antigen type tests. The chart on the right is what we've seen in the last 7 days, and if you remember the last time I was with you, that last 7 day specimens collected was right at 69,000, and so you can see that the significant decline in testing. We're in the last 7 days, the public health sites have collected a little over 14,000 specimens. And so those numbers have declined significantly in the last several weeks. Next slide, please. We still, as really every state public health agency, are struggling to get access to rapid testing supplies. The federal government really purchased the majority of those supplies and have different programs where they're either sending them to people's addresses, or most recently, they're sending rapid testing supplies to long-term care facilities and community health centers. But DPH has distributed over 1.8 million rapid tests to various entities. About 53% have went to health departments, and then they distribute them out to other entities within their local regions that have requested it. Long-term care facilities, our shelter facilities, fire, EMS and fire agencies, hospitals. Since the last time I was with you, I believe we at that point had distributed about 1 million tests. And since then, we've distributed about 800,000 more. And we continue to work with our vendors to try to acquire testing supplies, but most of our testing supplies are on back order right now. And the reason that we were able to push out so many in the last few weeks is we did have some testing supplies in our warehouse facility that had expired, but the manufacturer extended the expiration date on many of those test kits. We were able to send out some of the supply that we had on hand. The next slide, please. I believe this is the last slide that I'll present. This is our school testing program. Obviously, our goal is to keep kids in school, and one way we can do that is through all-free testing. This particular program provides free testing to school systems. We've been working very diligently to enroll schools into this program. And since our last meeting, we've added 26 new schools. We currently have about 190 school systems that are currently either participating or enrolled and going through the process. And so we are seeing some increases in that. There's a lot of school systems in the state. And this program is for all of the K-12 systems. And so we continue to work with the school systems and through our partners to get the word out that we do have this program in place, and it is available not only to the schools, but it's to the students, but to faculty, staff, and family members of the students as well, which is a new addition that we were able to add to that since this Omicron wave. So in summary, as you can see, we continue to offer testing even though those numbers have declined. All of our health department sites, our public health clinics, and our partners are vaccinating. Those numbers are plateaued as far as vaccinations go, but we continue to encourage people, as you saw in Dr. Drenzick's data, vaccinations and booster is really what prevents you from having severe illness, disease, and hospitalization. And so we want to continue to encourage that, and we will continue to encourage that. So with that, I'll be happy to take any questions.
We'll just talk about.
Maybe addressing Dr. Cheek.
Thank you so much for your update. And as we move forward to the younger children, 6 months and above, receiving vaccinations, currently the same locations planned, or how are we addressing that anticipated new rollout of vaccines?
Sure. So what we're currently doing is obviously partnering and making this vaccine available to pediatricians, to physicians that primarily treat children. But we are encouraging all of our providers that are vaccine for children providers to enroll as COVID providers. Believe it or not, they're not all COVID providers. And so we are working closely to encourage those because they also reach that population. And we will continue to work through AAP as well as other associations to reach out to providers to enroll and offer this vaccine. And one more thing, Dr. Rodriguez, I did want to mention, as part of our outreach, we still have our mobile teams in place. Our core is our mobile partner. We've got 12 teams that are statewide that are every day out offering vaccine in small communities. Those particular teams are designed to be nimble. They're designed to go into communities. And while they may only offer 15 to 20 vaccines a day, they're reaching a population that in most cases is difficult to reach. And then Fulton County has, I believe, 4 teams that are funded by Fulton County that also is offering these mobile teams that go out into the community. And so we still are offering unique events with them, and they partnered at churches, at barbershops. They've been in parking lots of supermarkets, places where people typically, we want to make it easy for them to be able to get vaccinated. And those teams are still in place and still doing some very important work.
Great. A follow-up to Dr. Cheek's question and your comment. The vaccine providers have dropped down 19% since the start. Any particular reason why? I mean, that's about 600 providers that are no longer active. Has it just been a normal process of attrition, or has it been a process in the system that has not let these folks to participate? Anything that we could do? It seems from what you're saying that this number should be increasing, not coming down.
Absolutely agree. The number of providers, we've had some providers that have just said that they are for a variety of reasons decided not to offer the vaccine anymore, that they've moved on to other vaccines. One of I think the biggest challenges that we've heard from providers is the wait period. You give the vaccine and people have to wait, for that 15 to 30 minutes based off their what they filled out on their forms. Mm-hmm. That has been one of the biggest challenges because as they are seeing more patients, they're having to spread out those appointments for that, and they don't have the space to do it. Gotcha. And so I think logistically, that has been one challenge. We've offered seminars on how providers can still offer this. but it's still one of the biggest challenges, I think, with this particular vaccine.
And there are the storage issues.
And as Dr. Toomey had mentioned, we don't have the storage issues as we had before. And most of these vaccines can now be stored at normal laboratory grade refrigeration. But the logistics of the scheduling of having someone be monitored for 15 minutes has been probably the biggest challenge.
Okay, sounds great. And then the other data that I found surprising was the long-term care facilities having only 73% of their folks fully vaccinated, only what I think is 31% of their staff.
Yes, sir.
What are we trying to do there? I know that you're trying to do the outreach in that respect, but is there any other steps that are being taken to address this issue? Because this is by far one of the most vulnerable populations in that respect, for both severe hospitalization and ICU care and death.
So one thing that Georgia Healthcare Association has a partnership with a vendor as well that CMS funds that can assist facilities that have vaccination rates lower than 40%. But what we expect will happen as the mandate for getting vaccinated is in place, and we probably will see some increases in that population. But it's been a challenge,
Sure.
And the industry has readily admitted that has been a challenge. And unfortunately, that's the risk that folks who are outside of these facilities can bring it in. The way we continue to partner with them is just offering our assistance, connecting them with vendors, connecting them with partners that are adjacent to them. If a facility reaches out to us, we look for providers that are close by that we can partner that particular facility with to make it as convenient as possible.
But our communication has been very proactive. I don't want to leave you, Dr. Rodriguez, with the thought that we're just waiting for them to call us. We've been reaching out.
Yes.
We've been having meetings regularly with the Georgia Healthcare Association, which represents the long-term care facilities, and encouraging the pharmacies to work with them. So it's been an active engagement, but it's hard when individuals are just really unwilling to be vaccinated.
Great. Any other questions for Dr. Ruxton?
Dr. Coles again, maybe a question and an observation. I was wondering, it may well be that the decline in testing of late may be because you can't get any tests. Like,
No, that's a fair point.
And the
Absolutely
comment
fair point.
my follow-up comment is, my hospital hasn't had a test available in 2 weeks. I'm in rural Georgia, and our policy of late has been that we can't even take a patient to the operating room unless they test negative, and we can't get any tests. So my usual 15 to 20 operations a week have gone down to 1 or 2. And those are people that are dying in the emergency room, and I've got to operate on them with or without a test. And my office hadn't had a test now for 6 weeks. And we were one of the largest vaccinators here. We vaccinated we did over 12,000 vaccines out of my office, and we can't get a test.
Dr. Coles, I assume you're referring to the rapid tests, because we have plenty of PCR tests and plenty of capacity.
I'm talking about the PCR tests.
That's
what we use at the hospital.
That surprises me in hospitals. We have an incredible shortage of rapid tests, and have not been ourselves able to secure them, and as you know, are actually competing with other states and the federal government to secure these, and have gone to extraordinary lengths, including even in trying to get them from our own vendors to be able to get them. I'm surprised that the PCR tests are not available, and I have not heard of that being a shortage problem, and we'll be happy to look into that for you.
Yeah, that'd be great. I mean, I spoke with them this morning, and they said they're looking for other vendors, and I mean, they're trying to get very creative, but it is a big problem.
Yeah, we'll absolutely look into that.
Yeah, because that's the first I had. Certainly those rapid tests have nationally are an issue, but I have not heard that about PCR. We have no shortage of PCR throughout the state at all of our sites in our laboratory, but
I'll have my hospital get in touch with you.
No, perfect. We'll follow up on that and we'll get right on it. Thank you.
That'd be great. Thank you very much.
Thank you.
Thank you, Dr. Rustin. Dr. Timmy, closing remarks?
Yeah, I think the one thing you, Dr. Rodriguez, you queued me up to say, is there anything that you all can help us with? And I have to say that in the many years I've worked in public health, this is probably the first time I actually am worrying that we may lose our childhood immunization mandates. There's been so much visibility about mandates and vaccines and negativity and polarization around COVID that unfortunately it's spilled over into childhood immunizations with some very real threats and possible legislation to take away our vaccination requirements for children in school or daycare. I speaking for myself, who's old enough to remember polio and who lined up in schools back in the 60s but also I took care of kids with Haemophilus influenza B, had children seized in my arms, had children crippled from Haemophilus disease in their joints. And now most parents have no idea what Haemophilus influenza B is, let alone worried about their kid getting it because we have eliminated it here in Georgia. The epigraph of Hib here in the state has been extraordinary since the introduction of vaccinations. I mean, to have a child get that kind of vaccine preventable disease or tetanus, can you imagine? And yet that is kind of the direction we're going if we don't truly re-engage parents and remind them and our legislators who may themselves not remember what this is like, how important these vaccinations are for children. And I really hope that you as leaders in the community and in the medical community can help us with that message to our policymakers, as well as others, because this is coming clearly because the public perhaps has lost trust in vaccinations as well. But that's all I have to say. Thank you.
Hey, Dr. Cheek, did you have a comment on that?
I think I can only say amen.
Mhm.
I think you and I feel the same way. We live through these horrible diseases
Correct.
in our residency trainings and all of our trainings, and saw so many children die and or be severely disabled related to just illnesses that are totally not in our world anymore. Have made my life easier because I don't have to take care of such sick children on a day-to-day basis. So, all I can say is amen. I know the Georgia AP and other, of course, state organizations, but especially the Georgia AP is working hard to help get the word out and make sure that the public and the legislators understand the gravity of making such changes to our laws. And normally on this board, we don't really spend lots of times, just bemoaning the things that we've already cured. But this would be just such a setback and such a step back in time that I don't think any of us on the board cannot not say something, because it would be horrendous to take that step backward in time. So that's just my comments, and I appreciate the efforts of the department and the efforts of the department of getting vaccines out. It has been a challenge, as you know, just for the public to accept these vaccines, and for all of us have to learn and understand about new techniques and new ways vaccines have been made. I think it has been a challenge for the public and all of us to grasp the new technologies. But yet, if you take a look at what they've done, which everybody in this presentation has pointed out, just the number of hospitalizations, number of deaths, compared to the people that are vaccinated and not vaccinated, the outcome or what they've done is obvious. But a lot of people are still very frightened of vaccines. So I think we all have to work hard to help people understand. And like I said, most importantly, not to take a step backwards in time and let these diseases come back and disable our children. So that's my, thank you for speaking up. And I agree, it's a frightening time if we let that happen.
Thank you, Dr. Cheek. I agree totally with what you just said. And we will be continuing the conversation with the Georgia AAP to see what we can do to make sure that they let their voice be known and educate our families in that respect. It's been an issue for a number of years, but it clearly is taking a whole new role in the recent times in that respect. Any other comments from the board members?
This is Bob Coles again. I just have one kind of follow up on that. I think that this slide that demonstrated the cases, hospitalizations, deaths by vaccine status, particularly the one that demonstrates cases and are close to non-existent, would be something that I would think in terms of a public relations exercise. If people out in the community could see that graph, I think it would make a big difference. I mean, I look at this stuff several times every day. I've not seen this graph, and it's shocking to me. And if it doesn't make a believer out of you, you're not going to be able to be convinced.
I would agree, and I also would agree that that graph were stratified by age group, especially that higher risk population, would probably be even more descriptive of what to expect under those circumstances. So I would encourage, as Cole says, to basically make that graph available, and also, if possible, stratified by age group so that individuals could really see what the risk in their particular age group would mean to be or not to be vaccinated in that respect. Thank you, sir.
Yeah, you're welcome. I'm going to enlarge this, and I'm going to post it in my waiting room.
Yep. Agreed. Okay. Any other comments by the board members? Our next meeting will be held on March the 8th of 2022. I think that we've basically gone through our agenda and talked about all that we've had. I'll entertain a motion to adjourn the meeting.
So move.
Thank you. In that case, the meeting stands adjourned. I thank everyone for participation. Dr. Mercer, did you have something? Just for the record, Dr. Mercer, we do know that you were on, and we did grant you attendance that you were on for today's meeting. I think your microphone may be off in that respect, not working properly. Anyway, I would like to thank all the participants and the public at large that listened to what was said today, and hopefully you'll take that information that's been described. I'd like to thank those that provided some information for us, and the board members also, and Dr. Toomey for their participation. Look forward to our next meeting, March the 8th. I hope everyone has a great week and stay safe. Thank you.
Yeah.
Meeting's adjourned.